Okay, welcome everyone. So now we are going to look at the dangerous disease named as cirrhosis. Cirrhosis is an end-stage liver disease characterized by irreversible diffuse fibrosis with formation of regenerative nodules. Decompensated cirrhosis refers to cirrhosis associated with jaundice, variceal hemorrhage, ascites, and encephalopathy. So these are the complications which occurs in decompensated cirrhosis. Cirrhosis most common cause of portal hypertension, and the causes of cirrhosis are viral hepatitis B and C, alcoholic liver disease, primary biliary cirrhosis, primary sclerosing cholangitis, acute hepatitis, hemochromatosis, Wilson disease, alpha 1 antitrypsin deficiency, and cryptogenic cirrhosis. So these are common risk factors for cirrhosis. Clinical features of cirrhosis are clinical presentations are patient first will become asymptomatic, then anorexia and weight loss occurs, then jaundice, coagulopathy, encephalopathy, portal hypertension develops, then ascites and esophageal varices will be there, and patient will bleed from mouth and are through GIT, and the signs will be in liver. Initially enlargement of the liver will happen, liver will be palpable, and then shrunken and nodular size will be there. Signs of compensated cirrhosis are xanthelasma or parotid enlargement, spider angiomata, enlargement of parotid gland, gynecomastia, splenomegaly, purpura, pigmented ulcers along with clubbing. Now, signs of decompensated cirrhosis are these are the most important signs and commonly occurs are encephalopathy, hysterexis, flapping tremors, ascites, caput medusae, edema, fetor hepaticus occurs. Signs of portal hypertension are splenomegaly will be there, enlarged spleen, ascites, distended abdomen occur. Ascites means when fluid accumulated in the peritoneal cavity more than 500 milliliter, then abdomen will be distended, ascitic fluid will be there. Caput medusae means dilated, superficial abdominal veins will be there, and esophageal varices will also be there. Now the investigations for cirrhosis are severity of disease. On the basis of severity of disease, we perform investigation like we perform liver function test, PT and APTT will be performed. LFT will show elevated bilirubin, elevated aminotransferase level, elevated serum ALP, serum electrolyte will show hyponatremia, creatine show elevated level of the creatinine, and CBC shows anemia, leukopenia, and thrombocytopenia. Causes of CLD are viral markers like hepatitis B and C can create this condition. Serum autoantibodies like in autoimmune hepatitis, serum immunoglobulin, iron profile, and copper ceruloplasmin level in Wilson disease, alpha 1 antitrypsin level in alpha 1 antitrypsin deficiency and disease of the liver. So, on imaging investigations will be abdominal ultrasound, CT, abdomen endoscopy, MRI, liver biopsy, and types of liver disease as well. Now, the prognosis of cirrhosis is based on these three grades, which we will not look at because this is a short review. So we will only look at the most important complications and features of this disease. Complications of the cirrhosis are ascites, portal hypertension, progressive heart disease, heart failure, hepatorenal, hepatopulmonary syndrome, spontaneous bacterial peritonitis, and hepatocellular carcinoma. These are complications. Now coming to the management, there is no specific management for cirrhosis. Basic management is treat the underlying cause, prevent and treat the complications, and the definitive treatment and stage treatment of the cirrhosis is liver transplant. So this is the only treatment regime for cirrhosis is liver transplant. Now, in other videos, we will also look at the complications of compensated hepatic disease, CLD, like portal hypertension, ascites, and hepatic encephalopathy, variceal bleeding, and other complications. Okay, so complications of cirrhosis are portal hypertension, ascites, variceal bleeding, and encephalopathy. So we will look at the complications one by one. Portal hypertension occurs when the pressure in portal vein increases greater than 12 millimeter of mercury, then that condition is known as portal hypertension. So there are different types. One is the prehepatic pre-sinusoidal, another is intrahepatic causes. Different types causing different causes. Portal vein thrombosis, splenic vein thrombosis can create prehepatic pre-sinusoidal portal hypertension, while intrahepatic causes are pre-sinusoidal, sinusoidal, and post-sinusoidal causes. Now, pre-sinusoidal are schistosomiasis, sarcoidosis, drug primary biliary cirrhosis, while sinusoidal are cirrhosis, most common metastatic malignant disease, and post-sinusoidal are veno-occlusive disease. Clinical features of portal hypertension are splenomegaly is a cardinal finding. Splenomegaly is marked in childhood and adolescence and is in adults is rare. Ascites occurs with post-hepatic and sinusoidal portal hypertension, not seen in pre-sinusoidal hypertension. Fetal hepaticus is also known as breath of death, characterized by smell of breath in cirrhosis due to portosystemic shunt of blood, which allows mercaptans to pass directly into lungs. Capit-Matteucci Cldr syndrome, where umbilical vein will be distended, and the complications will be ascites, varicose bleeding, hypersplenism, congestive gastropathy, hepatic encephalopathy, and renal failure. Now, the another complication is ascites, refers to accumulation of excess fluid in peritoneal cavity more than 500 milliliter. Is known as ascites, and pathogenesis is sinusoidal hypertension, hypoalbuminemia, and percolation of the lymph into peritoneal cavity, splanchnic vasodilation, and secondary hyperaldosteronism can create this condition. And ascites develops. Abdomen will be distended, fluid thrill and shifting dullness will be positive. Treatment will be sodium and water restriction. Diuretics, spironolactone is the drug of choice. Refractory ascites, diuretic resistant ascites should be given. And the treatment of refractory ascites are large volume paracentesis is first line treatment for refractory ascites. Transjugular intrahepatic portosystemic shunt tips should also be given, and it is surgical treatment. Now another is esophageal varices. Esophageal varices is a condition in which portosystemic shunt occurs when systemic and portal circulation shares common capillary beds, and it presents with hematemesis, bleeding in upper GI tract with the cirrhosis, and management will be assess the pulse and blood pressure, insert large bore IV line, normal saline should be given, talipsin should be given, prophylactic antibiotic, agent endoscopic band ligation, sclerotherapy, proton pump inhibitor should also be given. Endoscopic band ligation and sclerotherapy is the helpful, and pharmacological agent will be talipsin is a drug of choice, and balloon tamponade is also given in this portal hypertension. Or transjugular intrahepatic portosystemic shunt is a shunt which is also surgical management for esophageal varices. So in this way we can manage esophageal varices. And the another complication is hepatic encephalopathy. It is a neuropsychiatric condition because of cirrhosis. In this patient, it is a reversible metabolic disorder, and in normal liver nitrogenous substances are produced by the bacterial gut flora, and those nitrogenous substances uh, in cirrhosis, nitrogenous substance cannot be metabolized, result in formation of the neurotoxin, and those neurotoxins act as false neurotransmitters, and those can cause encephalopathy. Clinical features will be progressive mental status deterioration, hysterexis, constitutional apraxia, hyperreflexia, and EEG shows slow, diffuse slowing of the normal alpha wave and eventually development of the delta wave. So in this way this occurs. Now the treatment for this condition, hepatic encephalopathy, will be lactulose should be given, and neomycin, which decrease ammonia producing bacteria, and nitrogen production will be decreased, and rifaximin, and avoid triggering factors like relief constipation. Electrolyte uh, balance should be maintained. Mainly hypokalemia should be prevented. Treat the infection, decrease dietary protein as well, and in this way we can manage the patient. And the another complication is spontaneous bacterial peritonitis. Now, is peritonitis means inflammation of the peritoneum because of bacterial infection. It is a serious complication of the ascites. Clinical features are sudden onset abdominal pain, tenderness, absent bowel sound, fever, signs of cirrhosis, and ascites will be there. And ascites tape or paracentesis will show cloudy color, neutrophil will be increased, and organisms most commonly will present E. coli, pneumococci, and streptococci will be there. Management of SBP is cefotaxime and norfloxacin along with ciprofloxacin. In this way, these complications occur. And the another complication is hepatorenal syndrome. It is involvement of the renal failure along with ascites and cirrhosis, and mediated by the renal vasoconstriction. Vein vasoconstriction will be there, then fluid retention and edema will be there. Diagnosis criteria are cirrhosis with ascites, creatinine level is greater than 1.5, and there is no shock, no nephrotoxic drug usage, and no organic kidney disease is there. Types or of hepatorenal syndrome are two types. One is type 1, another is type 2. These are two types. Treatment will be octreotide, midodrine, and albumin infusion talipsin should be given. Treatment is liver transplant and hemodialysis is only definitive treatment.